Hi, everyone. Welcome to the PrecisCa GU Tumor Board. My name is Brian Reaney. I'm a GU medical oncologist at Vanderbilt, and I'm happy to be joined today by a prestigious panel of experts from around the country to discuss several cases. I'm going to go around and have everyone introduce themselves before we get started with our first case, and I will start with Dr. Siegel.
Good afternoon. My name is Carrie Siegel. I'm a genitourinary radiologist in the abdominal imaging section at Washington University in St. Louis.
Thank you. Dr. Shaw?
I'm Chirag Shah. I'm a radiation oncologist at the Tosca Cancer Institute at the Cleveland Clinic.
Thank you. Dr. Abel?
Yes, thank you for having me. My name is Jason Abel. I'm a urologic oncologist, a surgeon at the University of Wisconsin.
And thank you. And Dr. Jakaki?
Hi, everybody. I'm Alexandra Drakaki. I'm a GU medical oncologist at UCLA. Happy to join you today.
Thank you all for being here. So we have several cases across the spectrum of GU cancer to discuss today. And we'll start off, and I'll sort of describe the case and the question, and then we'll go through some specifics of the case. And then I'll come back to all of you for an opinion, depending on what the specifics of the case are. 72-year-old African-American male, history of T3B, N1, M0, Gleason 4+4, prostate cancer many years ago, radical prostatectomy and node dissection, slow biochemical recurrence since 2015, and now prominent metabolic activity at left lateral surgical margin with new lung nodules. And we're asked about recommendations for treatment. This patient presented with right lower abdominal discomfort and erectile dysfunction, good performance status, has a medical history of cervical spondylosis, no relevant family or social history. Cancer-wise, many years ago diagnosed, as mentioned, with T3B Gleason 8 prostate cancer, high volume disease with both extracapsular and seminal vesicle extension, got a radical prostatectomy and lymph node dissection, and then external beam radiotherapy, presumably in the adjuvant setting. It looks like then not even a year later, so about 5 months later, got started on hormone therapy. Looks like as adjuvant, because then we're told in November of 2015, the PSA starts to rise. So that is about 4 years, a little over 4 years after sort of surgery and adjuvant radiation. Gets CT scan of the chest and the abdomen and has an increase in lymph nodes. So must have had some lymph nodes with the PSA rise on hormone therapy and now further rise. We're now late 2016. CT-guided FNA and core biopsy confirms recurrence of prostate cancer. Patient is on hormones then from January of 2017 through October of 2018 is on standard Lupron monotherapy. PSA is further rising now. Now we're at late last year, early this year, up into over 6, and gets PET CT, gets an Oxyman scan that shows recurrence at the left lateral surgical margin, as well as now lung nodules. So progressive systemic prostate cancer, rising PSA, and now abnormalities on PET imaging. And this is the March of 21 PET CT. And Dr. Siegel, if you'll help us sort of work through this.
Sure. These are an axial image through the chest and through the pelvis of a FACBC study. And you can see if we just do the pelvis first, there's a large area of increased FACBC activity in the region of the prostate extending to the left. And then on the image on the right, there's a pleural-based lung lesion, which is FACBC avid, and there may be a lesion in the bone at the same level in the vertebral body.
Yeah, so multifocal recurrence / progression and a rising PSA on hormones is sort of what I'm gathering. And so the question is really about treatment options at this point. So I'll ask Dr. Abel first. Do you want to go in and resect that sort of surgical margin recurrence?
No, I really don't think there's much role for that one.
It was an easy question.
Yep.
How about Dr. Jakaki? This patient has, progressive prostate cancer. They happen to have PET imaging. I'm not sure they necessarily needed it because they had rising PSA, and we don't really know about conventional imaging. Presumably would have shown these lung nodules. But what What would be your next move in this patient systemically?
I think at this point, there are like tons of options. Obviously, we're going to look into clinical trial options, and those may require biopsy, so we can get a little bit more tissue, again, to send for temples, look for MSI, look for, our PARP inhibitor is going to play a role here, and then we'll look into the options that they have, either immunotherapy combinations, you can give chemotherapy, you can just start, if there are not trials available, even starting with adding Zytiga, Prednisone, and go on.
Two questions. One is, would you biopsy this patient strictly for the purpose of sending TEPIS testing, assuming that, say, this metastatic lung nodule's genomic profile is different than their prior prostatectomy many years ago?
I would probably do to make sure I'm not missing the neuroendocrine component.
Mm-hmm.
It's not uncommon when we do that, and then we end up starting people, on cisplatin etoposide or carboetoposide. So I think the main reason is not to miss something. We already know they have prostate cancer, they have new disease, the PSA is going up, but is there anything else going on?
So both for histology, and then obviously you could send that for genomic testing as well, for the reasons that you mentioned. And then my second question is around, given the lung nodules, given the visceral metastases, would that make you move towards chemotherapy earlier? Let's take the neuroendocrine component out of it. Let's say she's pregnant with prostate.
Not necessarily. I think, again, giving them Abiraterone Prednisone at this time point is a good first step. Save chemotherapy for later on. I wouldn't necessarily check the ARV7 mutation status, but that will be, again, my later approach when they start progressing on the dual antiandrogen. So I will be comfortable starting with oral agent and save chemotherapy for later.
How about, one last question, sorry, how about if it's liver metastases? That's a little bit of a different factor. So we know liver mets these patients are usually not doing well, and we don't want to lose time with hormonal therapy. These are the patients that I will just offer chemotherapy up front. Yeah. So liver would drive you to earlier use of chemotherapy, but other sites not necessarily. I think I agree as well. I think lung nodules tend to behave even more indolently. They don't scare me as much. It's a little bit of an oddity. I haven't had that many patients, but they definitely don't seem to behave like liver metastases.
Correct.
And Dr. Shaw, any role for radiation in this patient? I mean, he's multifocal disease, but it's kind of oligo. It's periprostatic. It's at least one lung nodule. I'm not sure we're showing all of them. And Dr. Siegel maybe thinks she sees something in the bone, but.
So he had radiation in the prostate fossa previously. So you can give radiation again, but it again comes with opening up a can of worms of toxicity. So there's data on different techniques, but given that he's had radiation there before, he has bony disease, pulmonary nodules that are concerning, I would probably favor systemic therapy. And then if there's oligo progression or if there's stabilization to just a few sites of disease, reconsidering it at that time.
Okay. And so just to summarize, this is a patient with prostate cancer status post-surgery and radiation, with rising PSA throughout hormonal treatment, and now with some soft tissue and visceral and potentially bone metastases in the setting of a rising PSA. And the recommendations is really just around that there are really multiple systemic options, probably more hormonal therapy in this patient. We don't really see a role for surgery or radiation, at least as presented.